Dysuria is otherwise known as a painful urination. It's sometimes described as burning. Many of the differential diagnoses are associated with the genital urinary system. We did find a few from the other systems like
many of the differential
endocrine,
diagnoses are associated with the genital urinary system.
The highest incidence of
we did
these
find
were UTI,
a few from other systems like GI,
BPH.
endocrine,
The most surprising one is
and
contact
gyne.
dermatitis.
The highest
an example
incidence of
was
these were UTI
dermatitis
and
that may
BPH.
cause dysuria.
The most surprising one is contact
In terms
dermatitis.
of contact
An
dermatitis,
example was
up to 1 in
dermatitis
5
that may
people
cause dysuria.
experience contact dermatitis. And the 3 UTI, BPH, and contact dermatitis were the highest prevalence. For the zebras of dysuria, we included causes from rare infectious diseases like adenovirus and herpes or a parasitic infection. Also, Zinner syndrome, and eosinophilic cystitis and urethral carcinoma. Across the different lifespans, the most common differential diagnoses of dysuria is UTI, and you can also see that most of the differential diagnosis include some sort of bacterial infection. To help with distinguishing a possible cause of dysuria, we put together this chart to help with your physical findings to lead you to your differential diagnoses. For example, pain at the end of urination, a possible cause would be a bladder or prostate problem. Or flank pain, hematuria, decreased urination, and bladder spasms. A possible cause would be urological obstruction due to a stone or a tumor. This will just help you narrow down to your differential diagnosis.
So when collecting information, when you're interviewing your patients for the HBI and review of systems, the number one thing you want to have in the back of your mind are your red flags. So with dysuria, our red flag would be dysuria with hematuria. So that's the first thing you want to ask. Other important questions to note are listed on the slide, but also thinking systemically. So does this patient have fever, chills, any weight loss, nausea, vomiting, any appetite changes, among the other questions to be screened. Your physical exam is going to be a more focused assessment, beginning with your general assessment. So if your general assessment doesn't point towards anything systemic, you want to move on and focus on specifically a skin assessment, making sure they don't have any cyanosis, erythema, ecchymosis in the skin, especially in the GU pelvic area. You also want to do an abdominal assessment, specifically ruling out some constipation issues that could be causing the dysuria, and then also assessing them for CVA tenderness, which will point you in the direction of some kidney disease, and then finally a GU assessment to really hone in what could be causing this dysuria. Is it more anatomical? Is it in relation to something else? Is it from any lesion in the area? And also assessing the quality of the urine. There are a few diagnostics that we could perform in primary care with a patient coming in with dysuria, but the number one diagnostic to perform would be a urine dip. With a urine dip, we could check the pH of the urine, the quality of the urine where it's cloudy. We can check the color, and we'd be able to tell too if the urine has any nitrates or leukocytes, which is point us in the direction of an infection, or if the urine has some protein, which would point us in the direction of kidney disease. And we would also be able to see if the urine has some red blood cells or blood in it.
So we put together a little case study. This involves Jamie. She is a 34-year-old female who presents to the clinic with the chief complaint of dysuria times 4 days. Her symptoms include urinary frequency, urgency, and mild pelvic pain. She denies flank pain, lower back pain, fever or chills, nausea, vomiting, vaginal discharge, a rash, or hematuria. We included some of the information from her SOAP note. Most pertinent would be her chief complaint, the pain when peeing times 4 days, and then her symptoms, pertinent past medical history. She is a type 1 diabetic. She did recently use antibiotics for her upper respiratory infection. She has a history of chlamydia when she was 19. And in terms of social history, she is sexually active but is using a spermicide as a contraceptive. We've included pertinent review of systems. She is fatigue. She denies a fever, and she's positive for frequency and urgency, dysuria, foul-smelling urine. She denies any lesions, any new rashes. Her pertinent physical exam, her vitals are stable. She is in mild distress. Her skin is clear, no rashes or lesions, and she has urethral tenderness. We included the pathophysiology of what leads us to a urinary tract infection, and her labs, her urine is cloudy. She's positive for leukocytes and nitrites, and has a trace amount of blood. The microorganisms, they cause urea to turn into ammonia, and it creates a less acidic environment, and cause nitrates to convert to nitrites.
Based on her presenting symptoms, her physical examination, and her urinalysis today, we are going to diagnose this patient with a urinary tract infection. The plan of care for her is we're going to get her started on some macrobid. So I'll get her on some antibiotics twice a day for 5 days. We can also give her a prescription for pyridium as needed for that pain that she's experiencing. And we want to encourage increase in fluids, and let her know that if her symptoms don't improve within the first 48 to 72 hours of starting her antibiotics, that she should call the clinic or come back to get that urine checked, and we could move on and do a urine culture and sensitivity to see if there's a better antibiotic that'll work better for her. I have narrated exactly what I would tell this patient in the best layman's terms possible for her to easily understand the source of her infection, what the UTI is, what to expect, her healing process, and her plan of treatment and care.